Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is John Moore, Managing Partner at Chilmark Research. John is a seasoned healthcare IT analyst, has been at Chilmark for over a decade, and has a long history working in the lab and in other healthcare-related work. Chilmark is a research and advisory firm focused on helping healthcare folks, the healthcare community, adopt and deploy IT tools to improve care delivery and improve the patient experience. Welcome, John. It's a pleasure to have you.
Thank you for having me here today, David. It's great to be doing a podcast with you.
Okay. So I gave a very high-level intro to Chilmark and to yourself, and I'm wondering if there's any other color you'd like to before we dive in.
Sure. So quickly, I'll just overview of how I ended up in health IT and then the work that we do at Chilmark. So I got my career started working at the lab bench, doing molecular biology work, doing cancer research and Alzheimer's genetics research. When I decided I didn't want to pursue a PhD, I was in the Boston innovation community, so I was able to tap into that and learn a lot from my peers as I made that transition out of doing the lab work into something more business of healthcare focused. From there, I decided to do a startup in the health IT space. I had been trying to avoid getting into health IT because my father had started Chilmark a few years before I decided to get out of hard science. But our paths aligned, and while I was doing my startup, it was a mobile health startup. So to pay the bills while we were bootstrapped, I joined Chilmark Research to help provide market intelligence around what was going on in the mobile health space at the time. This was in the early 2010s, so it was a completely different environment than what we're dealing with now. But some of the same problems are there. And Chilmark has always built a brand around really understanding at a deep level what are the implications of all this data in healthcare now being digitized, whether that be the interoperability problem or what are the best analytics, what are the best ways to ingest and transform that data for use for other purposes. But the ability to collect and utilize the information that we're now collecting for actual wisdom and knowledge to improve the care experience for both patients and providers has always been our focus here. And we do that through syndicated research that we publish ourselves and sell, or we do it through our consulting engagements that people come to us for when they have very specific needs.
Now, John, your father was always a hard-hitting analyst, asked the hard questions, and I know that Chilmark continues to do that today.
Yeah, that's definitely part of the brand. And it's something that I'm hoping to maintain as I continue to take over the business and leave my own imprint on what Chilmark is and does for the industry.
Great. So you gave a little taste of what the health IT environment was looking like when you first got involved. And I guess the real question for us today is to think about where are we today? How has the needle moved? Has the needle moved? What are the key questions we need to think about today? We're at the tail end. I think it's a perpetual conference season these days, but we recently closed at least one part of that season with a couple of big shows. And I'm wondering if there is anything that has come up either at those shows or in your experience otherwise that seems to be a focus or a promising innovation that we can be thinking about today. It's AI 24/7. I don't know if that's useful or not. It used to be blockchain 24/7 and unclear where that led us. And hopefully AI will lead us in a more positive direction. But I'm interested in your perspective. What's interesting to you and where are we headed?
Yeah, so great question, David. Thank you for asking that one. Sets me up pretty well for some good deep exploration of the topic. So when I first joined the industry, there was a lot of excitement about the possibilities of what could happen as technology that we see in the consumer industries and other enterprise industries come to healthcare, which was, as anybody in the industry knows, very late to the game when it comes to digital innovation and digital transformation that we have seen in other sectors. So there was a lot of hype. There was a lot of money flowing in. Meaningful use had just recently gone into effect. They hadn't necessarily started doing the MU program, but it was building up to that when I first joined the industry, or this part of the healthcare industry. And so going from those early days of just what are we going to be able to do with all this data now that's coming into the market? What are we going to be able to do to improve patient care? And how is this going to really drive value-based care were the narratives back then? The HIEs were really big. Then population health management, those were like big buzzwords for a couple of years there. As every year, there's a new buzzword. And I think that between this year and last year, it's the first time I've seen it be consistent between 2 years and everybody still be talking about the same thing they did last year, which is, as you pointed out, AI. The difference between this year and last year, though, from the events I've seen and from the conversations I've been tuning into on LinkedIn or on social media, is that the AI conversation has gone just from what I was just explaining in the early days of health IT. It's gone from all this promise and hype to people coming back a little bit more to ground level and trying to be a bit more pragmatic around what the possibilities are here. I think a lot of people just got super amped when they saw ChatGPT come out and the really easy nature and user experience of using these various generative AI tools. And as we see that also become applicable to other business and just, other enterprise industries, people are wondering what can it do in healthcare. And I actually saw Spencer Dorn, who is over at UNC. He posted this morning, talking about how technology solutionism is still a problem. And I think that's a really good thing to call out. But I also think it's something that people are becoming more aware of, especially this year and last year, as the tech economies got slammed by economic forces in many different ways. I think that a lot of people are acknowledging the fact that technology has a place, it has a function, but thinking that every problem that you have can be solved by technology is disingenuous. I saw.
So, John, is that what you mean by solutionism? Is that what he means by solutionism?
Yes, technology solutionism means that any technology can solve any of the problems that you have, or any problem you have can be solved by a technology. Okay. And the CIO at Common Spirit at Epic UGM last fall, he made the point that, and a lot of people that have been around tech for a while understand this, but it sometimes gets forgotten. It's 80 to 85% the people, 10% the processes, and then 5 to 10% the technology. So you really got to make sure that any technology you're developing fits into the workflows, the processes, the staff, what you already have in place. And I agree with that to a certain extent. I agree with the premise, but I think that part of the problem is that as we look at the technology use cases coming into the space, they've only had really incremental impact on the overall provision of care to date. There's been all this excitement, but between new companies going out of business, people not figuring out how to do certain business models that have worked in consumer industries, but not in healthcare, just any number of issues that we've seen across the market have resulted in the stalwarts being companies that are really just incrementally improving care, as opposed to making substantial, dramatic changes to how care is delivered into that care experience. I think that's something else that we're starting to hear more of as AI possibilities become more of the discussion. People are really starting to question, okay, what can we really rewrite about how care is delivered, how it's accessed, how workflows function, how it's paid for. As we get this data collected, I still think we're a ways off from value-based care. I think that's still a bit down the road. It's going to take a long time for us to really switch off of the way that the economics are set up today. But I think people are starting to see the potential to truly transform how care is delivered and move beyond just these minor incremental process improvements that barely move the needle, but they have some impact. And
we've only been talking about value-based care for 40 or 50 years now. So
exactly.
Yeah.
We've seen the highest uptick, though, of late with all the MA plans and things like that. We've seen the largest delta in growth over those 40 years, over the last decade, but it's still been very slow and a lot of people are hoping it would be further along by now. I said that's definitely one big topic. Interoperability and data quality, that's another thing that people are still talking about. The data quality issue is one of those things that people think that AI can help with, but also it's still going to be a problem when you're talking about training the AI when you have dirty data. Population health management is back. The user experience for both payers and for both the providers and for patients is another big topic of discussion right now, reducing the administrative burden on both sides of that equation, because right now, the kind of the key administrators in the entire industry are the payers, and they're pawning off a lot of the responsibility for the administrative work onto providers and patients now. And so there's a lot of companies tackling that. There's a lot of discussion around how to improve that. I really enjoy following Grace Cordovano, who always has really good takes on especially that patient administrative burden side. Yeah, those are the big things right now. It's really all about fixing the workflows so that you can make the best use of the staff that you have and then improve upon that. And from there, start to make plans to continually improve your processes.
Turning back, John, to your comments on data and data quality, I just have to interject and ask, and maybe ask you to comment. Didn't we fix all this, right? Between meaningful use and TEFCA and who knows what else? There's been a lot of change in the data of healthcare front. And it seems that a lot of that change, speaking as a non-technical person, is around data standards and technical standards. And I hear you saying that the problem is not solved.
No, so it's definitely not solved yet.
Help us connect the dots.
Yeah, so TEFCA and the QHINs and what the feds are doing right now through the ONC, that is still focused on standards around USCDI. And so those standards are good. It's a good thing that we're implementing them. And there are other standards out there, of course, but the USCDI is really where the ONC is focused today. And that's the Office of the National Coordinator for anybody listening that isn't already familiar. And what's happening there is that USCDI is a very limited data set that has been standardized around certain elements and certain categories of data. It's not fully comprehensive. It's not pulling in a lot of the other data. And the way that the healthcare system works, the data exchange between a lab that's independent from a care organization, that's largely still done through PDFs. And so the EHRs can intake that, but a lot of EHRs still just take in the PDF and they don't necessarily map the data from the PDF into the right fields for the patient. So that's one example of poor data or data access. Another example is just every EHR, for the most part, is configured differently for every site that they're implemented on. And so that creates headaches with just the mapping from one site to the next because they aren't set up the exact same way. And then also documentation isn't always done the same way from one organization to the next. And so that creates problems with standardization as well because they have different internal systems that they're using to do clinical notes and other types of documentation. Aggregating that data from one site to another requires intelligence beyond just a straight up API from one pipe to the next. It has to have some kind of intelligence behind that to actually interpret where some of these various data elements need to be mapped when they're being collected into one new database that's aggregating all this data.
If you're just tuning in, this is Harlow on Healthcare coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is John Moore, Managing Partner at Chilmark Research. John, so we've been talking about sort of opportunities and maybe some barriers to progress. And again, we've touched on this already, but top of mind for many people these days is artificial intelligence. And I wanted to put to you the thought that the real opportunity in healthcare for artificial intelligence tools, or generative AI in particular, may be in custom tools, perhaps built on top of LLMs, but really customized and based on particular data sets. Rather than putting a question to an LLM, put a question or put a task to an LLM that's been tuned and trained on particular data sets. Do you see any action in that sort of area?
Oh, yeah, plenty.
To a specialty or some other way in which we can carve up the system?
My God, I don't even know what isn't being attempted right now with AI in healthcare. It seems like everybody is trying to figure out how they can apply either a deterministic kind of AI, which is more like what LeanTOS does, or what some of the other systems out there do, where it is you give the same prompt, you get the same prompt out the other end, or you get the same result. Whereas some of the predictive generative AI, you can give it one prompt and it can give you a totally different response. So there's definitely a differentiation there in terms of just the type of AI. I think that personally, I'm very skeptical of the predictive models because there's not really intelligence there the way that we would hope there would be. And if you can't audit and rely on the same responses to the same prompts, that's a problem in healthcare. So I think that one thing we're seeing is an uptick in what's called retrieval augmented generation, which is when you take one of these big LLMs and then you train it on your specific data set. So it only pulls from that. And that tends to be a lot more deterministic because it's only looking at that data set, but it applies the logic from the large language model to that data that you're putting in there. And so you're seeing Oracle, they're rolling out a partnership with Cohere to basically allow people to set up their own enterprise AI within their organization. And that's one of the things that they are pushing with their new OCI framework or their new OCI infrastructure is the ability to quickly spin up a localized AI that's built off of the Cohere foundational models. You have Anthropic and Claude, which is personally my favorite for doing content generation if I'm going to use any of them. I really applaud because Anthropic has started from day one with doing a focus on ethical and responsible development. And I don't exactly remember everything that they do, but they have good credibility around that area from a lot of the people that do really understand the stuff. In the near term, we're going to see a lot more experimentation with patient messaging and clinical documentation because those are really good applications of the generative AI technology. It just, to your point, does require some fine tuning. It requires some localized training so that it understands what the local resources are that patients might have access to if it's a messaging between the patient and the physician. On the clinical note side, like I was saying earlier, it needs to be fine-tuned to document the way that organization is actually documenting clinical visits. But we're going to see a lot of kind of administrative and operational functions get picked up by AI. There's Notable, which does a great job of really focusing on the operational side. So there's just a lot of stuff happening more on the back office right now than on the forward-facing clinical side. There are a number of companies that are working on clinical, but those are typically more in the experimental and pilot phase still, just because nobody's quite ready to give up autonomy around the care decision making at this point, though radiology has come the furthest in that regard.
Turning back to something that you mentioned earlier, John, there is a wide swath of healthcare operations that maybe can't be fixed by imposing a digital solution. It's people. It's what we used to call wetware.
Yep.
And there's that line of demarcation. And how can we use some of the digital tools that are coming in to help maybe turn the supertanker, so to speak, and help the human element of healthcare learn, evolve, change, adapt? What do you see happening on that front?
Where is that line of demarcation?
There's operations, right? Generally, you're looking at some tools, I imagine, that are focused on operations. But as you were saying earlier, a lot of the operations issues are really around people.
Yeah, and there are a number of companies that are trying to displace people in areas where basically anything that's a repeat function or a redundant and very duplicative type of a task or a activity that somebody needs to take when we are talking about delivering care, anything like that can be in theory automated.
Right. And we make people happier by doing that, right? Let people, quote unquote, practice at the top of their license. So that's a good thing. People shouldn't feel threatened by that, right?
Exactly. And so that's one of the things where we see AI having a really good utility, or just technology in general, not even just AI, but just technology. It helps people get the information that they need in order to operate at the top of their license. And it helps at the enterprise and organizational level apply the human capital in the right areas where they're needed. So technology does help us a lot with understanding patterns, with predicting, say, the patient census so that you can staff areas of your organization appropriately. But at the end of the day, you are still going to need hands on deck to specifically deliver care and engage with the patients directly. But yeah, anything that is repeatable and redundant technology can be applied to that task or that function that a human is currently serving. And as you said, you want people to be operating to the top of their license. You don't want nurses constantly doing rounds on patients that don't need any checkup, right? You don't want them always checking in on multiple floors or in and down the halls, when instead you could outsource that by putting some cameras in your patient rooms and have a dashboard or a command center where there are some nurses or some other trained staff that monitor those instead of having somebody manually go through every individual at every room and check on every patient manually. So that's another area where you can blend technology with the workforce piece.
Yeah. So that's an example of some inpatient, a very specific inpatient use. I'm wondering if you're looking at more broadly different kinds of opportunities for improvements or innovations based on type of service or care setting. Where's the opportunity? We spend big bucks on inpatient care, on procedures, but I imagine there are opportunities there, but there may also be opportunities in particular other settings, in particular other specific specialties. Is there movement? Do you see movement? Are you looking into movement in particular specialties, care settings, different kinds of service lines?
Yeah, so a couple of things that I'm excited about, and I think that other people see an opportunity here, is the shift for hospital at home. Bioformis calls it the timely discharge. But basically, you don't need to keep an individual in an inpatient bed for an extra couple of days when they've stabilized and they are clearly okay. Instead of doing that observation in the hospital, you can send them home and have some monitoring devices in the home that can then free up that bed. Because one of the real big issues today is capacity issues with both just the number of beds in certain geographies, as well as the diminished workforce. There's just a patient flow problem that a lot of people are tackling. And so anywhere where technology can really help with that patient flow, whether that be initial triage and routing a patient instead of sending them to the ER or urgent care, you're able to get them an appointment with the right lower expense clinician. Triage is a big thing when it comes to the capacity and the workforce issue, because that can take a lot of the burden off of frontline staff and the admission staff so that people aren't always waiting in the ER for multiple hours at a time. Remote patient monitoring ties into the hospital at home, but it has a lot of broader applications that can be really interesting down the road as we look at chronic disease management. Although the Peterson Health Institute paper that came out recently raised a big question about whether or not some of these chronic condition management applications and services are actually having a impact on the care of the individuals that are using them.
And whether it's in fact cost effective.
Yes, for the impact that they have. Exactly.
As we're wrapping up, I want to leave you with one last question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or maybe expect to find has changed drastically?
So I have come to learn that even though 5 years might sound like a long timeline for this industry, it's actually a pretty tight time frame. So I don't expect a huge amount of change, but in 5 years, I do expect us to get to the point where the ability to apply AI to real world data to generate new evidence around how to better provide care and better align patients with the right care pathways, I think that's going to be truly transformative in the next 5 to 10 years as we really start to hammer away at these large language models and other AI tools like natural language processing and OCR and some of the other technologies that have been out for a number of years, as we're actually able to get to the big data insights and get to the patterns in care delivery that can only be accessed now that we have these massive data sets that have been collected over the last 10, 15 years. I'm really excited to see what comes of that in terms of innovations in just care delivery, period. And the ability to get drugs approved much faster for additional indications when it shows that something has an impact. I just sent out the newsletter yesterday for Chilmark, and in it, I commented on this story that I saw in The Atlantic about cystic fibrosis treatment. There are now mothers that they found out through genetic testing that their child will be born with cystic fibrosis. But because these medications are only currently approved for patients 2 years and older, they have to go onto the black market basically and find these drugs that are very expensive secondhand. And the reason they're doing this is because so far it has been shown only anecdotally, not in a full large-scale RCT, that if these drugs are taken in utero, certain kind of common birth complications and significant developmental problems that babies are just come out of the womb with can actually be prevented entirely, because the developmental issues with cystic fibrosis start while you're in the womb. And so the ability to be able to generate real world evidence that this is something that the FDA should expedite and approve more quickly would have a massive impact on insurers actually adjusting their best practice so that, as soon as a baby is identified as cystic fibrosis positive, they can get that medication instead of having to find it on their own and would take months to do that. So I think seeing a topic like that yesterday, tying in with this conversation, I think that's what I'm most excited about, is the ability to really expedite access to life-saving and life-changing medications and care pathways.
Fascinating opportunity for citizen science and advancing the ball in clinical care.
Yep.
Well, thank you, John. Pleasure to speak with you.
Hey, it was my pleasure too, David. Thank you so much for having me on the show.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.